So, with all of that, thank you so much. I'm excited to talk today about perinatal depression. And so that's what we're going to talk about. And, it's really important, I think, in this topic and really in any topic when we think about people who are pregnant and really consider sort of risks versus benefits, is to really balance risks versus benefits of treating depression throughout pregnancy and really thinking about risks not only of starting or continuing medications, but also potential risks of either discontinuing or not starting medication. So not treating depression, right? So kind of on one side, there are potential concerns about ongoing medication use, maybe antidepressant use, and safety of antidepressants on the developing fetus. There are also maybe misconceptions, not so much maybe now, but for a long time around pregnancy being an emotionally protective time of life, and that a person could not develop depression during pregnancy or in the postpartum period. And we know that absolutely is not true, right? Many people do, and we'll talk about that in just a second here. But upwards of 1 in 4 people who are develop postpartum depression or perinatal depression. On the other side, when we think about, not treating or discontinuing medications, there are concerns about untreated depressive disorders, and that could be either major depressive disorder or bipolar disorder, and what that means to the safety of the person who is pregnant, right? So often a woman, but not always, but the maternal safety or the safety of the person who's pregnant. But then also, and we'll talk about this a little bit more, the wellness of the person who's pregnant directly impacts the wellness or lack thereof of the developing fetus. And so we really can't just think about one or the other by themselves. We really have to have strong consideration for the holistic risk versus benefit of the dyad of both the person who's pregnant and the developing fetus. So with all of that in mind, thinking about perinatal depression. So perinatal depressive episodes occur during pregnancy or in the first 12 months after delivery. They're one of the most common medical or psychiatric complications of pregnancy. And we know that death by suicide is very, very high in the postpartum period for women compared to other periods of life. Postpartum depression is diagnosed in about 10 to 20% of pregnant or postpartum women, but the estimates are that the actual prevalence is actually a little bit higher, upwards of 1 in 4. So the reason why the diagnosis isn't quite matching what the estimated prevalence is has to do with what is thought to be underreporting, and sometimes this is related to feelings of shame. So someone feeling like, well, I shouldn't feel this way. I'm supposed to be happy during this period of life, and so what's wrong with me? I'm not going to seek out help because shame is sort of blocking that. So one study actually found that 16% of people with diagnosed postpartum depression reported symptoms to a health profession or their general practitioner. So only 16%, right? So that means 84% of patients with diagnosed postpartum depression did not report those symptoms. So what are the clinical symptoms of perinatal depression? So we know that before that, just to mention, about half of the perinatal depressive episodes occur prior to delivery. So about half occur prior and half occur after delivery. And typical symptoms, some of them overlap absolutely with what we think of as depression not associated with the perinatal period. So certainly sadness or depressed mood, anhedonia, sleep disturbances and appetite changes, concentration difficulties, as well as psychomotor alterations. So either psychomotor agitation, sort of a revving up, or a psychomotor retardation or slowing down, guilt, fatigue, and suicidality. However, we know that there are many symptoms that occur in the pregnant and postpartum period that overlap with some of these symptoms of depression, right? Particularly sleep changes and appetite changes. And so we don't want to screen someone in for having a depressive episode if some of their symptoms are not related to depression, but in fact related to the being pregnant or postpartum. We do know in people who do have perinatal depression that anxiety and insomnia in particular are more prominent than people who have non-perinatal depression. So some risk factors for perinatal depression. So on the left-hand side, we can look at risk factors during pregnancy, and on the right-hand side, we can look at postpartum risk factors. So when we think about during pregnancy risk factors, history of any depressive episode is absolutely a risk factor, as well as anxiety in the pregnant person, lots of life stress and lack of social support. There is evidence that if the pregnancy is unintended or unplanned, that is a risk factor. Whether someone is on public insurance or not, so being on public insurance has been shown to be a risk factor. If someone has a history of intimate partner violence, that's a risk factor. Lower socioeconomic status or lower education, smoking, and then also either having being not engaged in a partnership or having a poor quality relationship. And then during the postpartum period, again, depression and anxiety, stressful life events, but also things like a traumatic birth experience. If someone had a preterm birth, if their infant was admitted to the NICU, again, that low level of support, again, thinking about that history of depression. And then also finally, if that person is having a difficult time with chest feeding. I do need to update some of the wording on some of my slides. I'm acknowledging that now, but I'm transitioning over to the phrase chest feeding rather than breastfeeding from an inclusive perspective. So screening for perinatal depression, there is a screening tool that is more specific to the perinatal and postpartum depression period, and that is the Edinburgh. So the Edinburgh is the most frequent screening tool in this situation. It is 10 items. It takes under 5 minutes. There's not a need for high health literacy at all, and it's been translated to many, many different languages. It also has been applied and is evidence-based in use in women who are not pregnant, as well as men who are not pregnant. So it really can apply to many different populations. But what it does and why it's different is it inquires about anxiety, which the many traditional depressive rating scales and specifically screening scales do not include, right? Like PHQ-9 does not include that, whereas EPDS does. The other difference is it does not really get into appetite or weight changes, right? The way that PHQ-9, for example, does. And that's because we know those are often symptoms associated with the other condition the person has. So a little bit more about Edinburgh. If the score is greater than or is equal to 13 or higher, that indicates a high likelihood of depression. So it's a screening tool, high likelihood or not high likelihood. And one sample question you can see here is in the past 7 days, things have been getting on top of me. So someone can say, yes, most of the time I haven't been able to cope at all. Yes, sometimes I haven't been coping as well as usual. No, most of the time I've coped quite well. Or no, I have been coping as well as ever. So a great screening tool. Definition, just very briefly, there are varying definitions for perinatal, peripartum, and postpartum depression. ACOG says that perinatal depressive episodes occur in the first year after delivery or during pregnancy, and that's what we've been talking about. But DSM-5 is a little bit outdated in this area. It really defines depression with a peripartum onset as being during pregnancy or only in the first 4 weeks after delivery, which really misses many people who develop a postpartum depression, between sort of 5 weeks and 52 weeks. And then postpartum depression in the brexanolone trials that we'll talk about in just a second, which is the first drug that's been approved by the FDA for postpartum depression, occurred during the 3rd trimester of pregnancy or in the first 4 weeks after delivery. And some differential diagnosis, so baby blues or postpartum blues, they often peak around day 4 to 5, generally only last less than 10 days, and do not interfere with functioning. And that's the most important thing is this does not interfere with a person's functioning, whereas a depressive episode does. Also have to be thinking about bipolar disorder. We'll talk about that right at the end here if we have time. Thinking about medication-induced depression, certainly interferon, tamoxifen for breast cancer. There's a whole host of medications that can induce depressive symptoms and need to be assessed. And feel free to reach out to your pharmacist, your friendly pharmacist, and we'd love to help you with that. And then also thinking about other conditions like postpartum autoimmune thyroiditis. So impact of untreated perinatal depression. So there's a lot going on here. On the left-hand side is the impact to the pregnant person. On the right-hand side is impact to the fetus, the infant, or the child. I do want to just quickly make a note to not forget about paternal depression and the impact of paternal depression on the care of the infant or child, right? So thinking about that too. We can't forget about, all caregivers here. So, really thinking about the pregnant person for a minute. So untreated perinatal depression, increased risk of preeclampsia and operative delivery. We talked about maternal suicide rate, right? Maternal suicide outnumbers mortality from maternal hemorrhage and maternal hypertensive disorders in the postpartum period. It's a really big deal. Also, higher use of substances during pregnancy, reduced prenatal care, and inadequate maternal weight gain. And then thinking about the infant child fetus, infant child challenges with social interaction, difficult infant and childhood temperament, increased risk of preterm birth, low birth weight, and intrauterine growth restriction, and then even some evidence around things like developmental delay at 18 months in the person who was exposed, who was in utero when their pregnant person was having untreated perinatal depression. Okay, so antidepressants. Antidepressants. So they have been studied quite significantly, thinking about their impact on birth outcomes. So one thing is spontaneous abortion. So this has been shown to be associated with antidepressants, but these studies are super, super hard to do. They're very limited. There's so many confounding factors. They're not controlled for maternal illness. So it's really hard to draw conclusions about this, if it's the medication itself or something else that's going on. And further, we know that, for example, SSRI use that was discontinued even 3 months prior to conception in one study, for example, was associated with a 24% increase in miscarriage. So, there's probably some other confounding factor here that we're not studying or we're missing. So it's a little bit unclear here, but there might be an increased risk of spontaneous abortion in the first trimester. Birth weight and gestational age of infants were lower in people who were depressed, who were pregnant, that were on SSRIs versus people who were depressed who were pregnant who were not treated. So this is something that does seem to pan out, right? Is that there is probably a lower birth weight and maybe a lower gestational age in some infants that are exposed to antidepressants. However, again, it's important, you can't underestimate the importance of untreated depression and the impact of that as well on birth weight and gestational age. When we think about exposure, we're thinking about different potential concerns with first trimester versus third trimester exposure. And the big take-home point for treatment here is that SSRIs are not considered to be major teratogens. SSRIs are not considered to be major teratogens, although again, some data is mixed and some data is confounded. Most data is confounded. They're not considered to be major teratogens, except paroxetine, which might be. Paroxetine might be one exception. We do know that it causes, in some studies, it's been associated with cardiac defects. Some studies have actually found that's not the case. So again, it's still unclear, but if any of them cause this, it would be paroxetine. And so you can see the evidence here. There is maybe a dose response, but again, it's hard to know if there's other noise coming into this data. So because it's unclear and we have other SSRIs that don't have as concerning or concerning signal here with regard to cardiac defects, most experts continue to avoid general use of paroxetine in perinatal depression and in women who are planning to become pregnant or trying to conceive. That said, there is evidence that shows that switching from one antidepressant to another in someone who is pregnant, and so therefore exposing someone to two antidepressants, can be less optimal than keeping someone on one antidepressant. And so if someone is on paroxetine and becomes pregnant and they're tolerating it well and it's working for them, it is a discussion that could be had whether it would be appropriate to continue that specific person on the paroxetine. That would be the one exception here, but really trying to avoid use of paroxetine in people who are trying to become pregnant and maybe who could become pregnant would be something to consider. It also has a lot of withdrawal symptoms, so that's the other thing that we're always thinking about. So with the preterm birth, it can shorten the pregnancy. We're talking, up to a week, so 3 to 7 days. So, again, risk versus benefit of treatment versus not treatment. And risk factors do include higher dose, being on it for a longer period of time, choice of antidepressant, as well as, interestingly, use in the second trimester. And you can see the ones that are more associated with preterm birth are TCAs, drugs like amitriptyline. So using an antidepressant, we really reach for our SSRI antidepressants, with the exception of not using paroxetine. Postnatal adaptation syndrome is something we see with third trimester use. This is basically SSRI withdrawal symptoms is the way that I think about it in my head. So anyone who's taking an SSRI and abruptly stops taking it will often develop withdrawal symptoms depending on the drug and the person. So that's true if the SSRI exposure is in utero or orally, right? Same exposure. And so we know SSRIs cross the placenta. So about 30% of those exposed to SSRIs have clinically significant postnatal adaptation syndrome in late pregnancy. It has a few other terms you can see listed here. The symptoms can last for as long as 6 weeks and usually occur within hours to days after birth. In most patients, they do resolve within days to weeks, but again, they can last for up to 6 weeks. It's most often reported with paroxetine, fluoxetine, and venlafaxine. And then again, there are other possible mechanisms, but in my mind, it really makes sense that it's an SSRI withdrawal phenomenon, and you can see the symptoms listed here in the picture. So lethargy, tremor, respiratory distress, abnormal crying, irritability. Some late postnatal effects and neurodevelopmental effects. So this has been studied quite a bit here. There is one thing that does seem to be more clear, although again, all of this evidence is confounded, but it really seems like this has been studied over and over about the link between antidepressants and autism spectrum disorder. It seems like the most important thing here is maternal mental illness. So if the person who is pregnant is having untreated depression, they are the person, the fetus in utero is more likely to develop autism spectrum disorder. So it's the depression, not the antidepressant. It really looks like that. Now, there is some evidence that does follow people out through 18 years of age. And I think, as we get more and more evidence, we'll learn a little bit more following people longer term. But right now, I do really think it's important that we think about it's not treating with a med. It's not med or no med. It's our choice is med or untreated disease in some situations, not all situations. And I will just steal my thunder for a quick second and mention it here and mention it again later, which is with mild depression, therapy is just as effective as psychotherapy is just as effective as pharmacotherapy. So with mild depression, the choice is antidepressant or therapy, right? And so there, I think it's more clear, but we're talking more moderate to severe depression. So thinking about, okay, what about stopping antidepressant? So if someone stops an antidepressant and they have recurrent major depressive disorder and their antidepressant is stopped because of pregnancy, they have 5 times higher risk of relapse of their major depressive disorder. So having another depressive episode. Other studies have found no increased risk overall, but have identified higher risk populations. So the ones that we really have to be most concerned about not stopping an antidepressant in are those who have severe recurrent disease, so have had 4 or more lifetime episodes of depression, or those who have not been euthymic or stable from an affective mood perspective for at least 6 months. So if someone has had a hypomanic or manic, or if it's just major depressive disorder, a depressive episode in the past 6 months, then they are at higher risk. If they have hypomanic or manic, they shouldn't be on an antidepressant without a mood stabilizer, but that's another conversation for another day. The other thing I also want to point out is we have a lot of work to do to research exactly what's going on here, but there have been some studies that have shown that women who are Black and women who are Hispanic are at increased risk of having another episode of their major depressive disorder after stopping antidepressants in pregnancy. So the overall approach to perinatal depression, if we look on the left-hand side and think about mild to moderate, and the right-hand side, think about moderate to severe depressive episodes. But before we get to there, thinking about the top, for every person, we're going to maximize evidence-based treatment, evidence-based non-pharmacological treatments. And we're going to emphasize the importance of NEST, nutrition, exercise, sleep, and self-care, time to self. And then if we have someone with mild to moderate depressive episode, we want to think about psychotherapy. CBT is one of our best treatments for mild to moderate depression. Also considering weighing the risks and benefits in the specific patient and employing shared decision-making about whether an antidepressant is appropriate. That would be more when you get into the moderate side of things rather than the mild side. Moving over to moderate to severe, this is where we're really thinking about an antidepressant. The benefit tends to outweigh the risk, and thinking about, for severe in particular, combining antidepressants and CBT. Using the antidepressant, we're going to go with the SSRI because there are fewer risks there. We're going to avoid polypharmacy, so avoid like switching while someone's pregnant. We're going to avoid paroxetine. Consider what someone responded to in the past. Within the non-paroxetine SSRIs, they're all pretty reasonable, but we often will lean towards sertraline, and that's because sertraline is also preferred in patients who are chest feeding. And so it's a great option that someone can continue on through pregnancy and then through breastfeeding. Always use the lowest effective dose, but make sure it's in the therapeutic range. So with sertraline, that means at least 50 milligrams per day. But if someone's still pregnant in their third trimester, you're probably talking about 100 milligrams per day. You need to increase the dose in second and third trimester, avoid undertreating to avoid exposing both untreated or undertreated depression and the drug, right? If we're going to use the medication, then we want to actually treat the disease. And then third trimester tapering of antidepressants is not recommended. So it's not recommended to do that. It's recommended to manage the postnatal adaptation syndrome when it occurs, not try to mitigate it beforehand. And then super briefly, we have allopregnanolone is a treatment, allopregnanolone is the physiologic basis for the first treatment we have for postpartum depression. In short, you have rapid changes in these in the postpartum period, and that's thought to be related to the etiology behind postpartum depression. And so what we know is that GABA receptors and the specific delta subunit of those receptors downregulate. And so that's supposed to happen, that normally happens. But in people who develop postpartum depression, that downregulation doesn't occur. And so you get this rapid decline in allopregnanolone levels and postpartum depression happens. And so a new medication came out a few years ago, was approved for this. Major limitation of this medication is that it is an IV infusion that's administered over 60 hours. So we're talking a multiple day continuous infusion, and you can imagine the logistical considerations for that. There is now an FDA approved oral version of a different medication in this class. So we do have more options now that are coming out. Some resources here I want to point you to, especially the MGH Center for Women's Mental Health, but also Sick Kids and the CDC resource as well. And then just in one quick second, don't forget about bipolar disorder. So we know in people who are pregnant who have bipolar disorder, untreated bipolar disorder, or withdrawing mood stabilizer in pregnancy is very, very, very highly associated with recurrence of a mood episode, and also in some patients, postpartum psychosis. So continuing treatment reduces episode recurrence rate by 66% in people who have bipolar depression, in addition to thinking about our patients with major depressive disorder. So with all of that, thank you so much.